Well, welcome everybody to these actually the first rounds in which critical care and transplant has coordinated their rounds. And before I ask Stephen to introduce our guest speaker. Okay.
I think if we get this, should we do this? No. No. Okay, you'll have to speak.
Well, I don't know if they can hear. So this is the first time that critical care and transplant has organized a joint. Can you hear now, Marcel? No. Can we get them back and find out why this is not working? Can you give me this one?
There's a volume control.
Does this work? No? Perfect.
What's going on? Try the other one.
So it maps the hand mic.
No, it's not working.
Try this one.
Well, they won't hear it here. You hear? No? Can we call them back?
Yes, I will call them.
So we're going to start while we try to get this together. So this is, again, for the third time. This is the first time that we've had transplant and critical care do its joint rounds, and we thought that we would use the notion of organ transplant after medical aid in dying, and we were actually given yesterday's introduction of C14 that I guess we're going to talk about a bit. It's even more timely than either of us had anticipated. So we have two speakers, Jennifer Chandler from Ottawa and Eugene Bereza, and so I'll just make a few notes about Gene, that he's probably the authority in Quebec on medical aid in dying, and quickly becoming one authority in Canada on this same topic as C14 was going to wind itself through Parliament. And so we're lucky that we have him here as on our staff to badger. And I'm going to now ask Stephen, who's Director of Transplant at the MUHC and whose idea this actually was initially, to introduce our guest speaker.
Okay, thank you very much, Peter. And I think the mic is working actually. And so thank you to the entire critical care and donation group. We talked about this a number of months ago. We thought it's time for the two groups to increase our collaboration academically, and that would have certainly spin-offs in the quality of care delivered. And so we're grateful for the organization of the critical care rounds, and to Irene for having set it all up. It's a pleasure to welcome our special guest today as Jennifer Chandler, who's the Bertram Loeb Research Chair and the Faculty of Law at University of Ottawa. Jennifer researches and writes about legal and ethical aspects of advances in biomedical science and technology, with a particular interest in neuroethics, organ donation, and regenerative medicine. She's written recently on legal implications of advances in neurotherapies and neuroimaging technologies, the use of neuroscientific evidence in criminal law, regulatory policy related to medical practices such as organ donation and transplantation, and the ethics and laws of scientific inquiry. She joined the University of Ottawa in 2002 after serving as a law clerk to the Honourable Mr. Justice John Sopinka of the Supreme Court of Canada. And she's on a variety of editorial boards in the field and teaches mental health law and neuroethics and medical legal issues and tort law at the University of Ottawa. Summaries of all these discussions can be found at www.jenniferchandler.ca, a very nicely done website, I must say. And she's an investigator in Core 1, that's the ethical, legal, and social impact core of the Canadian National Transplant Research Program, and an active member, I must thank her also, and on-the-spot legal consultant for the Canadian Society of Transplantation. And so we are hoping to have a posting of this presentation both on the CNTRP website and on the Canadian Society's YouTube channel. When we'll confirm and send out an email with those addresses at a later date. We're also very grateful to Astellas Pharma Canada for an unrestricted educational grant to support this event today. And with that, I turn over the podium and this technological accomplishment of linking everyone together to Jennifer. Thank you, Jennifer.
It's trickier than doing a transplant, is getting the slides up. So thank you so very much for being here and for inviting me. I'm delighted to be here. And I'm not thanking the federal government because I had my talk all prepared at the beginning of the week, and as you know, some new legislation showed up yesterday morning, so I had to add another 6 slides. And one trick is going to be not taking up too much time. I'm just checking here so you can watch the time. Okay, so what I propose to do is take about 30 to 35 minutes and then get out of the way, and Dr. Breza will have a few words, and I'm looking forward very much to your thoughts as well on this topic. So just by way of very quickly setting where we are. So we had the Carter decision in 2015, which announced that our criminal prohibition on medical aid in dying, or I sometimes call it PAD for physician-assisted dying, but I'm trying to switch to MAID. Our federal criminal prohibition in certain circumstances was unconstitutional. And then, as you know, there began this sort of churn of wondering how the governments were going to reply. Quebec had, as you know, its own legislation, and then yesterday the federal government has responded with a piece of legislation that's significantly narrower than was recommended by the joint committee, the federal committee that had been asked to look at it. So many issues came up that have been moved on. Issues around access by advance directive to mature minors and access to MAID or PAD for people whose suffering is psychiatric, solely psychiatric, are issues that have been pushed off to a future date. But I think we can anticipate that there are going to be some potential issues around the constitutionality of what was proposed yesterday, which is restrictive. And I'll talk more about that in a moment. At the time that the Carter decision came out, there were a couple little voices saying, wait a minute, what does this mean for organ donation? Is there going to be a group of people now who may wish to donate who are dying in this, for us in Canada, novel way? And how do these two practices come together? And if they should indeed come together? I'm not sure what's beeping, but hopefully we won't self-destruct. But as you can see, concern expressed on the top left, and this is a more inflammatory Fox News headline, chilling concern, harvesting organs, better off dead, Belgium pushing. And also in the top right, but in the bottom right, you see a case of a woman. This wasn't actually a MAID or PAD case. I'm just going to use the MAID to mean medical assistance in dying for ease of reference. MAID case, but a woman who wanted to actually argue for MAID and to donate. So these cases are coming up of patients who will ask for MAID and want to donate, which is what inspired me to start asking exactly how would this fit legally and ethically within the Canadian context. And also just to buttress my argument that these cases are going to come up, and I suspect that's perhaps why you're all here and wondering about it. You're anticipating these will come up as well. This is practiced in Netherlands and Belgium, and recently there was a bit of a fuss because a patient who was accessing voluntary euthanasia wanted to donate, and the systems weren't in place, and this person was refused. And this made it to the Dutch Parliament, and it caused a bit of a public outcry. The public wanted this person to be able to do this, and so we have the Dutch health minister saying this should be possible, and then moves to actually change laws or clarify guidelines to make this possible. So my point in showing you this is just to suggest that We may think this is a fringe issue, that this will only affect a rather small number of patients, but it seems to me inevitable that there will be a request at some point and a response will be needed. So perhaps maybe think about what that response might be earlier rather than later. And I just point out that DCD started in Canada at the request of a patient who questioning why could this not happen. So just for those of you who are interested and might not have seen it, Bolin et al. Just in February published the bottommost document, which sets out not an ethical analysis, but a practical guide. What are the practical steps in the way we're doing it in Netherlands? So that might be of interest to some of you to see what they say. I've incorporated their discussion in the slides that follow. Okay, so let's switch back now to one or two points about Bill C-14, the Carter case, and the Quebec legislation. And then after I've talked a little bit about what Bill C-14 might mean for organ donation after MAID, I want to switch more into a more general ethical legal analysis that looks at bringing these two practices together within the context of organ donation and transplantation legislation. So we have these two bodies of law to look at least two bodies, the physician-assisted dying MAID legislation and the organ donation transplantation legislation, and potentially other legal principles as well. So we'll start with this, which is the constraints being put on MAID. So what did our Supreme Court say? They said a bunch of things, but they said there is a right of access to those who fit these criteria. Competent adults who consent, give clear voluntary consent, and who are suffering a grievous and irremediable medical condition that causes enduring physical or psychological suffering that's intolerable to the individual in the circumstances of their experience. So a subjective approach. So far, so good. Questions were raised. Well, what about mature minors? Does psychiatric suffering fit in there? Pure psychiatric suffering? Well, Parliament has spoken now, as of yesterday, with narrower scope of eligibility. So the criteria are you have to be, they're essentially the same with a couple of differences. One, clear 18 years old is specified, eligibility for public health care to avoid suicide tourism, so to speak. But the main differences take place in elucidating what is the meaning of grievous and irremediable medical condition. So here, there's a lot of borrowing from the Quebec legislation. So we have serious and incurable condition. We have advanced state of irreversible decline in capability. We have enduring physical, psychological suffering that's intolerable. And then we have the mysterious natural death has become reasonably foreseeable, but no prognosis about amount of time left is required. So we reads this and says, well, heck, that's all of us, right? Unless you're planning to go hit by a bus, your natural death is foreseeable at some point, right? So there's a lot of consternation about what the heck this actually means. It seems to me what they're getting at is something like what's in the Quebec legislation, that you are at end of life. Also a little bit imprecise in the Quebec legislation, but I think it's some sort of amorphous, not very beautiful legal drafting for death is around the corner. How far around the corner and how many corners unspecified, but it's something that we have in our contemplation relatively soon. Now, this raises a lot of question marks about what does this mean, but it also potentially restricts very much the scope within which we're now talking, the number of people who will actually be valid organ donation candidates, because there's a whole range of people suffering chronic pain conditions, neurodegenerative conditions, whose death is not reasonably foreseeable. And those might be the people who would be most apt to be eligible medically for organ donation. So before this, I thought that there was a larger scope for bringing these two fields together. After this, I'm not sure, but I also think that this provision is going to be challenged in the courts relatively swiftly because on its own terms, it's inconsistent with what the Supreme Court said. One of the patients in the Supreme Court case had spinal stenosis, and the court said she has a right to PAD. Well, under Bill C-14, I'm not sure she would have access. I'm not a doctor, so I don't know how quickly spinal stenosis would kill you, if indeed it does at all, but it would seem that she's foreclosed from access contrary to the direction of the Supreme Court. And of course, we have a case like that of a Sherbrooke man who set about starving himself. This was reported this past week here in Quebec in order to satisfy the requirement that he be on the edge of death or whatever it was, about to die at the end of life. So these two classes of cases are not well dealt with in Bill C-14, and I suspect I'm not 100% sure this law will remain in the form it is, but it remains to be seen. So I've essentially covered this. I am pointing out implications for organ donation in C-14, confusion over this meaning of eligibility. So which are the patients that might possibly go for MAID and then organ donation? Well, we've got a restricted number, and possibly removing a lot of those who would likely be eligible for organ donation. If we leave those with terminal cancer, for example, that's evidently not going to be the population which would be involved in these two practices, most likely. So it remains to be seen sort of what's going to happen there. So a couple of other aspects of the bill that I think are relevant to the practice of medical aid in dying or MAID. So I'm going to get to this in a moment, and I expect it will raise some eyebrows, but one of the suggestions has been that in bringing these two practices together of MAID and organ donation, one could have something that's called euthanasia by organ removal, anesthetic and removal of organs from a living person. And the question there is, why would one insist on a lethal injection, a heart attack, anoxic damage to the organs, and then removal when it's actually legal to kill people? Why does one insist that a particular method of bringing about death be adopted? This is the argument, right? Now, there's a lot of, we can say more about whether it's wise to go in that direction or not, but I think it's foreclosed by the words of both the Quebec and now federal Bill C-14, which refer explicitly in their definition of MAID to the administration of a substance that brings about death. So this would seem to preclude bringing about death by removal of the heart and other organs. But we'll talk about that anyway, just because I think it's useful to be complete in understanding the various ways this could be done, kind of muse about that and compare it to the other two possibilities. So this leaves two possible ways by which these two practices could be brought together. Donation after cardiac death, after MAID, or living donation before MAID. So let me now talk, sorry, I'm speeding a little bit to try to keep an eye on the time. I've mentioned this as well. The medical aid in dying definition in Quebec also has these two questions that the Bill C-14 has. Okay, so this is where I'd like to go now. I have, this is meant to sort of be a chronological or a time metaphor with death at the moment of the heartbeat there. And I want to talk about the possible moments at which organs could be removed from someone who's undergoing MAID. So you could, with item 1, before the death, remove organs from a living donor. Moving to the end, after DCD, after death occurs because of lethal injection, and then the usual protocol for waiting minutes after cessation of heartbeat elapses, you could go ahead with a standard DCD type protocol. Or in the middle, you could have this organ donation euthanasia or removal of organs to bring about the death. This, of course, gets a little bit confusing about whether that constitutes a deceased donation or a living donation, since they're simultaneous. And so there's a legal confusion about whether you follow the rules for living donation or follow the rules for deceased donation. Another reason why one might not want to go in that direction, in addition to the fact that it doesn't fit the existing definition of MAID. Okay, so let's start with considering some of the issues, ethical and legal, that might arise with living donation before MAID. So I'm speaking now from the perspective of an Ontario lawyer considering the Ontario legislation. So just to warn you about that in case because I haven't fully understood the differences between the Quebec and the Ontario, but I think Dr. Bereza will be able to help with that. So inter vivos living donation, clearly legal. There's a system for consent. There's rules around the age of the person who's eligible to do it. And so this would not seem to pose a legal controversy. Ethical controversy, one wonders perhaps, I don't think there's any issues specific to this kind of donation that wouldn't perhaps apply in the others. An ethical issue that might apply across the board is a concern that the decision to undergo one might affect the other, that there's a kind of a sense that you may be more apt to ask for MAID if you feel you can also donate. And that might cause some concerns, perhaps, about the nature of people's decision making. Now, where things get a little bit more murky and difficult is with what's been suggested in the ethical literature, that one could have expanded living donation. So let me try to explain what's contemplated here. If living donation is currently permitted for non-essential organs, as it is, fine, no problem so far. But if you know that the person will undergo MAID before their loss of essential organs would otherwise bring about their death, have you violated the dead donor rule in removing essential organs? So the idea is you would remove a series of essential organs, obviously not the heart or lungs, but liver, kidneys, knowing that that will eventually bring about their death, especially the liver, obviously. But you know that they have consented to and scheduled MAID before, however many hours before they would die from the loss of that organ. And so it's been suggested, why couldn't one have this expanded living donation? The argument again being, why put organs through a period of anoxia with the risks to recipients? Now, there's a whole bunch of problems with this. One of them is, what if the person changes their mind? So between the removal of the essential organ and the MAID, they say, I don't want the MAID anymore. Well, then the team that has removed essential organs is in a rather awkward spot of having brought about death, essentially, or having grievously harmed, if just remove both kidneys, for example, someone who now must remain on dialysis. So there's sort of, in addition to ethical, there's kind of legal uncertainties about what this would mean and what their status would be at that point of someone having withdrawn consent. All of the legislation maintains that the party who goes for MAID must be able to withdraw their consent before it happens. And so this kind of practice might be inconsistent with the spirit, if not the letter of those rules. So it seems to me an unwise idea, but you can see the tension that's developing between trying to optimize the success of the transplants and in fact sometimes follow the autonomous wishes of the donors who might actually ask to do it in this way, and yet remain sort of in a good state from the ethical legal perspective. So the next possibility, deceased donation after MAID. This, I think, is perhaps the most straightforward way that the systems could be brought together. And in principle, permissible. The usual rules that apply legislatively about deceased donation would follow. So you would have separate teams bringing about the death, obviously, and procuring or removing the organs to avoid the conflict of interest. Same sort of competent and informed consent. But yet, we still perhaps have some ethical concerns that might arise. So if advanced matching and planning is done, all things are set up, will a person at some point feel committed to going ahead with MAID? Is there a sort of an influence that is put on them by virtue of all the effort, knowing there's people teed up and waiting for these transplants? Is there going to be an awkward point about the ability to withdraw consent that may develop in these cases? Another tricky issue raised in the Ballin article is, what do you do if the patient himself going for MAID doesn't raise organ donation? Are you allowed to ask them about it? Should you ask them? Apart from allowed, is it ethical to ask about it? And at what stage would one ask? Now, there's rules in deceased donation, DCD, about, make the decision to withdraw ventilation before this question about donation is broached, in order to keep those separate and not to have sort of conflict of interest perceptions. Is this going to be possible in this way? Is it going to be the same patient, same physician talking about MAID who will be in a position of raising the possibility of organ donation? I think this is not clear what the answer is here, and I think that the ethos in the ethical literature is the idea that there may be a benefit to the patients of being able to have this opportunity, so it's almost a harm done to patients to not at least advise them that it's a possibility. They may derive some form of comfort psychologically from it. Is the flip side to the concern about undue influence, perception of taking advantage of someone at a very difficult time. So that's something that will have to be sorted out as well. What are the rules and best practices around whether it can be raised and by whom and at what point for this class of patients? Another practical obstacle for MAID and then organ donation is that it appears that the MAID may have to be administered right next to the operating room, or at least in a hospital. And so the possibility of dying at home, which presumably is much more comfortable and comforting for everybody concerned, will presumably be foreclosed. So patients will presumably have to be fairly motivated to donate to sort of go ahead with donation in this way. And it's been suggested that permitting living donation prior to MAID is one way to get around this. You can do your donation, then you can go home and have MAID at home. So this third category, which I'm not seriously proposing, but I want to discuss just so that we can sort of explore sort of the logic of the system that's being set up here, is what exactly is the status of the dead donor rule, which is sacrosanct in organ donation, when you're in a jurisdiction that permits MAID, right? So we have already said it's okay for a certain class of patients to request medical assistance in dying and for doctors to bring about their death. So how do we fit that with the dead donor rule? And it comes down to a question of, do we have reasons to insist that medical assistance in dying be administered in a certain way or not? Why lethal injection versus something else? If you have a patient who's strongly motivated, wants to optimize all chances of the maximal ability of help they can give to recipients, and asks for this, on what basis would one refuse? And I guess there's a couple of reasons why we would be reluctant to go there. First of all, there's discomfort of clinicians and public relations issues. But I think there's this legal confusion also of, well, what consent rules and procedures do we follow? Does it count as the living donation, which is limited to people of a certain age, consenting in a certain way, etc.? Or do we follow the rules and procedures applicable to deceased donation? Well, that's not clear, and when they happen simultaneously, there's not an obvious sort of set of rules one would apply. I think there's a good public relations reason not to bring the practices together in this way. I think that even though there's always the risk of the public perceiving that there's a sort of an exploitation of the suffering or the death of patients at any point when ventilation is being removed from someone who's seriously brain damaged, you might perceive that there's a sort of a benefit being taken. I think it's the risk of that kind of perception is more acute here, obviously, where the two are actually being merged into the same act as opposed to being kept separate with separate teams, etc. So those are a variety of reasons why this might not be advisable, even if it would perhaps maximize success of the donation. So I've got a collection of other ethico-legal issues to float for you. Some of these I am in the process continuing to work on, but one of them is, and this was raised at a talk I gave on this topic in Alberta a month or two ago, and someone said, well, what if I have a recipient who objects to the idea of MAID, is ethically opposed to receiving a transplant from someone who's died in this way? Do we have to tell them? What if they ask? What do we tell them? And I said to myself, I suppose I could imagine someone whose life depends upon a recipient who really wants an organ, maybe preferring not to have a transplant, a life-saving transplant, because of this principle. And so, anyway, I thought about it, and in current practice, there's all sorts of information that's withheld. People are not told about lifestyle factors, about a potential donor, other characteristics. Only when the information points to an increased risk of a poor outcome or disease transmission from the transplanted organ does that become part of the informed consent. So my inclination, without having, I'd love to hear what you think, would be that the manner in which the person dies is not part of the information that must be disclosed, even if a recipient might have an ethical obligation or a conscientious objection of some sort to having an organ from that source. And one of my reasons for this is paternalistic. It is basically, once you make it a piece of information someone could access, then a recipient no longer has a plausible deniability argument for themselves. Well, I just don't know. I can't know, therefore I'm not responsible for taking an organ that could potentially come from a source that I object to. If the information is accessible and they don't ask, they might continue to ask, should I have known? Do I have one? I could have known. And it's better just to say this is not information that anybody has. paternalistic of me, but I think that that's all in is probably the better answer. Next one. What to do about a potential of a directed posthumous donation in the context of MAID? So directed donation is frequent for living donation, not typical for deceased donation. Now, I understand that occasionally it happens where someone is passing away and a close family member or friend needs a donation, and sometimes they're permitted to direct a donation in that way. But it's sort of murky, and there are precedents of people wanting to donate organs to celebrities, families who have someone pass away, and they say, I want to direct this donation over to this famous Natalie Cole. There was a case in the U.S. of a desire to have a posthumous donation directed to a specific celebrity. So my belief is that that's generally not done. When there is a directed posthumous donation, it is typically to a close family member. But these are questions that come up also in this context of MAID. People who have in contemplation the moment of their death can time it according to people whom they are aware of that are in need, and then make that request. I want it to go to this person. And what will our answer be at that point? Is there a reason to treat this differently from other cases of families that might want to try to do the direction? I haven't thought my way through that. I think there's perhaps a greater claim ethically, if not legally, to a kind of an ownership or proprietary interest in the organs of the person himself or herself who's passing away as opposed to their family. But this is just a feeling. I don't have a good kind of legal or logical argument for that. So something to sort out. And then finally, my last ethical legal issue I wanted to raise is almost in anticipation of a transplant program refusing to do this. And it caused me to wonder, could a patient who's refused actually have a complaint against that program? So, or to put it another way, is there a right for a medically suitable patient for donation after MAID to be considered for donation? In other words, is the fact of their death by MAID an acceptable reason to refuse them? We may refuse people all the time for lack of resources in the hospital, lack of their medical suitability, concerns, for example. We allow family override where we're concerned that going ahead with the donation would cause a lot of upset to the family or a public relations kind of nightmare. So there's already a variety of reasons why we might refuse the donation from someone who's medically acceptable. But there's a whole bunch of reasons where it wouldn't be acceptable. Imagine, as a thought experiment that I want to come to at the end, someone who, completely making this up, but who said, we don't want your donation because we discriminate against whatever race you happen to be. So there's something that feels like this is not a permissible reason to refuse a medically suitable donor. So which class does the MAID death fall in? The suitable, acceptable reason to refuse, or the not acceptable reason to refuse? So I thought about this and tried to think of the legal framework within which this question would come up. And so under human rights code legislation in all the provinces, they vary by province, but essentially say something along the following lines, that a person has a right to access services, goods, facilities without discrimination on the basis of race, gender, et cetera, including disability. So what would it mean to say someone who wants to donate after MAID and is being refused, does that constitute discrimination contrary to human rights legislation on the ground of disability? There are precedents for this, because you might be thinking, wait a minute, this isn't, taking a donation, taking a gift. How is that the provision of a service, a good, a facility? Does anyone have an obligation to take a gift from anybody? And there are clearly precedents in which people have felt this. So we have a variety of human rights complaints in several provinces of situations where men who have sex with men are barred from donating blood, again, a voluntary donation. Blood donation by somebody with a cognitive disability is now being complained of before the federal courts. There's a case in Ontario of someone who wanted to donate bone marrow and had a physical disability and was turned down and complained this was discrimination on the basis of disability. So whether or not we think it feels natural to say it's discriminatory to refuse a gift, we have a number of people attempting to donate bodily substances who clearly feel that it is a discrimination to refuse them on the basis of sexual orientation, cognitive or physical disability. So how would this argument be structured in the context of MAID. So we have to ask ourselves, is the option to donate a service, good, or facility? And, well, I think one can make a variety of arguments. I point to the kind of rhetoric that one finds on organ donation websites and policies talking about how the opportunity for donation is a family's right. All patients have a right. Now, clearly, this language is not meant to articulate a legal position. I think what this is meant to do is convince physicians who might be reluctant to approach grieving families to view it as an obligation to do so. I think it's a rhetorical kind of move as opposed to a legal move. But nonetheless, this framing of there being a right suggests, wait a minute, this is something we feel resides in the patient and directs us to consider the possibility that donation is a psychological benefit and to ask whether it should be withheld and on what grounds from a dying patient. And a little quote from a patient with ALS who said, "I'm so glad that in spite of my disease, there's something I can do to help others in a significant way. I can't do what I want in my life. Here I can do something." So making someone's exit easier. There is a psychological benefit for those who do want to go ahead. Is it appropriate to deny them, and on what grounds? So another tricky legal problem, and then I will get out of the way, is the legal analysis would also have to say, okay, you're allowed to deny people benefits, but just not on certain grounds. Is the restriction of donation from people who die by MAID, does it constitute discrimination on the ground of disability? Is it always going to be people with MAID, who go for MAID, who have a disability? And is the donation really about the manner of death as opposed to the disability? Here we get into very complex, murky legal territory, which I'm not going to take you through. That's for my students get to suffer that stuff. The answer being, I think you can come up with a little bit of an argument here that if it's only people with certain disabilities who will die in that way, and they have a right to access that form of death, then a refusal to allow them the other options that might be possible, including organ donation, does constitute a restriction on the ground of their disability. So a little bit of a speculative argument, and I take you through it only to raise this question about, is there a harm done in actually refusing, and what might be the justifications? If we're concerned about public relations issues, about conflict of interest, these might be legitimate reasons to refuse, but I think they have to be thought through carefully in order to answer this kind of critique. So I'll stop there, perhaps. I think I've sort of made it. Okay, I'll get out of the way so we can leave some time for questions. Yeah, I'm not quite sure how to do that.
Thank you, Jennifer. We'll have questions at the end, I think, and we'll now get the Quebec perspective from our own Eugene Bereza, who has led the effort in Quebec to develop this legislation. Thank you, Eugene.
Thanks, Stephen. Actually, in the interest of time, I'm going to forgo my slides, because I think it's important to have. We never have enough time for questions and discussions, which sure is a really exciting part. So first of all, thank you, Professor Chan. I think that was very stimulating, exciting. It's when I was preparing for this, I thought, what's the big deal? I mean, the pool of potential candidates is going to be so small. Why are we talking about this? But I think you're right. First of all it takes is one case like this. You don't have to have 1,000 cases for it to be a huge ethical challenge. And secondly, things change very quickly. When I was a resident, none of what was happening today would have been conceivable, and here we are. Things change very quickly. So I think it's important for you to have raised our awareness of what may be coming down the pipeline, even though some of it may seem like a bit far-fetched. It may not be. I will not actually go into an elaboration of what is in Bill 2. I think it's a whole separate talk with downtown halls. For those groups, perhaps critical care, emergency room, who we haven't reached out to yet, maybe we can come another time and go in more detail. You ought to know what's in the bill. But the take-home message on Bill 2, for those of you who haven't come to those sessions, is the first time you have a patient in our hospital who makes an official request, who is eligible. You probably won't know all the regulatory frameworks or all the forms to fill and all that. The only thing you need to remember for now is you get in touch with the Groupe Interdisciplinaire de Soutien. Each institution has to have such a group, and that group's mandate is to, in fact, come in and help support the team and the patient and the family in terms of logistically, the forms, how it goes, what happens. So if we don't remember anything else about the bill, remember that you have a GIS, and the chair of our GIS at the MUHC is Dr. Dion, so that's who you reach if you need to. The only other thing I'd mention about Quebec is that just out of interest's sake, and then I'll move on to the organ donation part, what is the difference as I understand it, and the bill C-14 just came out yesterday, so we'll have to study that a bit more carefully, but there are a few significant differences that maybe I'd bring to your attention, subject to some interpretation, obviously. And on this one, Professor Chan, you need to correct me if I'm getting the legal part wrong. My understanding for Bill C-14 is, first of all, it was brought in by the Federal Minister of Justice. So it's really dealing with the criminal code. And my interpretation of what that means is basically for in Canada, if you do this, filling the criteria of what's in Bill C-14, if it passes, then you're immune from criminal prosecution, period, right? Whereas in Quebec, which it didn't come through justice, it came through health care. It was articulated as a range of health care options, and it gave our community, in a sense, a positive right to a care. It's not optional. A patient says, I want this. If they meet the criteria, institutions are obliged to provide. So while physicians, nurses, and pharmacists can invoke conscientious objection, institutions cannot. So in that sense, it's quite different. Quebec has given our citizens a positive right to something that institutions must be able to provide. Whereas I think the C-14 basically says, if you do this under these constraints in the other parts of Canada, you won't be prosecuted, which is a very different thing. Then we'll see what the other provinces do. What are the other main differences so far that I can see? And this is an early read. In C-114, it basically suggests that you could also do assisted suicide, which is strictly off the books in Quebec. Number two, in Quebec, we've restricted this to physicians. So while you have a multidisciplinary team getting things ready, it's only a physician can do the active injecting of the medications, whereas in C-114, it can also be a nurse practitioner. I think a significant difference, but then subject to interpretation, how we understand the words, is in Quebec, you have to be imminently dying. Now, while you will not find a number in the bill or in the regulatory framework, the unofficial, off-the-record understanding for those of us who've worked on this with the Collège des Médecins is we're really talking about days, weeks, maybe a few months. We're not talking about a year and a half, 2 years. I won't be able to back that up with a source, but that's the common understanding. As a former English major, though, I would suggest that the language in C-114, which is reasonably foreseeable, is in effect somewhat larger. So case in point is the case we had in Quebec earlier in the week, or a neurodegenerative patient who says, I have ALS and I have 14 months left to live, would probably qualify potentially under reasonably foreseeable. I can foresee that within a year and a half you might not make it. They might not be imminently dying. So in that sense, Quebec might be more restrictive. And finally, the language used in the federal legislation it goes beyond just having an illness which leads you to end of life. It includes a condition. And that's, in my view, understanding the language, and also a broader situation. So again, somebody who's a quadriplegic, is that an illness or is that a condition? You have a disability. And so potentially that makes the scope larger. Quebec, in that sense, is much more restricted. So in some ways, what C-14 became was more restrictive than what was planned to be, but it's still probably larger in scope than what the Quebec legislation is. And so we're going to see how that plays out. If a bill ever passes, how do we reconcile whatever differences there will be. Finally, on the issue specifically of organ donation, to the extent that I could find, and I have to admit I looked at this rather quickly, I could not, unless somebody can correct me, I could not find anything either in Bill 2 or Collège des Médecins framework or anywhere else that specifically legally addresses that issue. How, when, if, can you? I don't see that anywhere. The only thing I could find, and it's in the PowerPoint that I'd rather not do, is that we do have a group, forget the actual acronym, but it's a science and technology ethics working group that reviews many technologies from an ethics perspective, who will be apparently bringing forth a draft document at ACFAS on May 2nd and 3rd. And so everybody's waiting with bated breath to see what their analysis and contribution might be. I have no inside scoop on what's going there, but May 2nd and 3rd we should be having some sense of what our community in Quebec has looked at. And that's as much as I'm going to tell you, and the rest I think should be open for discussion. Thank you.
Okay, so we do have a few minutes, so as traditionally, we'll start at the Jewish. Paul, anybody there have a question for either of the speakers?
I don't think anybody here has any questions. I'm still trying to process this. I think we're all still trying to process it. Thank you very much for a very interesting and thought-evoking talk.
Okay, thanks, Paul. General?
No questions at the general.
That's all this time for questions. Who has any questions?
Not sure which general that was, but at the Montreal General. Jennifer, thank you very much. The timing of your talk is literally made to order.
There's another 14 upstairs on the 14th floor.
Oh, the ICU.
Anyway, thank you very much. I don't think there's any talks from the ICU group here.
Where else? At the Sacré-Cœur. Est-ce qu'il y a quelqu'un à Sacré-Cœur qui veut poser une question?
They may not have the same controller. Yeah. Well, she's going to be there at 2:30.
She's going there. Oh, okay. Okay, so then let's open it up here. I'm sure there are questions here. Marcello, go ahead.
We got the microphone?
Come
on. You're like a talk show.
Yeah, really.
Come on down.
Thank you for the talk. I have just a practical question. Having taken part in DCD, one main concern that we have is that we declare death by circulatory criteria. That means that we wait until the arterial line goes flat, we count 5 minutes, and if there is no restarting of the circulation, no beats on the EKG, no beats on the arterial line mainly, then we proceed with the organ procurement. I find this topic a bit touchy and difficult, but if we can let the imagination a little bit wild, one concern we have is that the time you're waiting for the circulatory arrest to occur, the patient goes through a prolonged period of desaturation, low blood pressure, that often is going to compromise organ function. So I can envision a situation where I pre-oxygenate the patients to a very high PO2 and administer medications to induce the MAID after the request of the patient that are going to cause the circulatory arrest very fast in a way that the 5 minutes is going to be achieved very fast and without any preceding period, prolonged period of saturation and hypotension, which then would increase viability of the organs. Is there anything in the legislation that precludes the use of medication that induce, for example, fast circulatory arrest like potassium and stuff like this, which looks really ugly? I agree with that. Just for a practical question.
Mm-hmm. Huh, wow, yeah. That's interesting. I guess what you're saying is what if the typical practice of MAID were modified expressly to optimize organ donation? What are the ethics and law of that? Huh. The difficulty is that the law itself is silent about the manner in which death is brought about. All it says is administer a substance that brings about death. And I guess the next question would be, presumably there's guidelines of the colleges of physicians, et cetera, that are being developed to set the rules and process of how you actually bring about death. And it would seem unwise to me to deviate from those policies just to maximize the donation, but perhaps it would be advisable for the colleges to contemplate should, in fact, there be... it strikes me there's nothing legally magical about the manner in which you bring about the death. It's sort of... because it's touchy, you don't want to be perceived to modifying and deviating from the sanction processes in order to
But the
optimize.
main concern is to maintain comfort of the patient.
Mm-hmm.
So if I meant the criteria of the college,
Mm-hmm.
the college de médecins is
Essentially telling us to provide general anesthesia
Mm-hmm.
for the death.
Yeah.
But it doesn't say anything about using adjuncts to general anesthesia that would speed cardiac arrest. So
Yeah.
as long as my main concern is to make sure the patient has the most comfortable death
That's achieved
possible,
already.
achieved,
Yeah.
other things that can be added, I don't seem to see this in the law or in the guidelines to specify anything against that.
No, and the other thing is in these cases, there's a possibility of getting fully informed consent too. These are, by definition, going to be competent patients. To even get access to MAID, they will be fully competent. So all of this could be discussed, whether they are willing to have things proceed that way. So yeah, I don't have a very good answer for you, I'm afraid. I would, it'd be nice if the colleges would consider this when they're discussing how this should be done.
Hi, I'm Prashant Chaudhary. I have a question regarding to what you termed euthanasia by organ donation.
Mm-hmm.
I'd argue that replacing someone's blood volume by an organ-preserving solution that is high in potassium, that induces fibrillation, actually occurs before organ donation, before organs are removed. So death actually occurs by injection of a substance prior to organ retrieval. And you could certainly envisage a circumstance where, without performing a surgery, you put a partial bypass circuit on, a cannulation through the femoral artery and vein, and inject that substance to cause death while someone is under general anesthesia. So I think it's very facile to say that this is foreclosed upon by the wording of the legislation, because it does not seem to me in any way to preclude that circumstance.
You could,
And the thing is going to be that someone will ask for that.
Yeah.
And at the end of the day, whatever frameworks the provinces and the colleges come up with, they will be challenged legally by someone who wants this, someone who's got a little bit of knowledge and wants this. And so I think it's going to be a real failing of the donation and transplant community if we don't have a good thought process about how we're going to deal with it when it happens. Because mark my words, it will.
Yeah, no, I'm in agreement with you. So just so, as a non-doctor, just so that I understand, what you're saying is one could administer a substance, not propofol and neuromuscular block, but
you
instead...
You administer all of those in addition to the organ-preservative solution.
Okay, and so that would constitute administration of substance, so it would be okay. But you say that death would not yet have occurred.
No, death would have occurred. The organs would not have been procured. So the actual act of removing the organs does not cause death. The injection of the substance causes it. In actual fact, even as we perform this kind of operation today, these patients are brain dead.
Yeah.
Dead by legal definition.
Yeah.
The thing that actually causes the circulatory arrest is the perfusion of the body with the organ preservation solution.
Okay, and that's distinct from a DCD, obviously. Yeah. Okay, got it.
I got a question at the Montreal General. Jennifer, one of the issues you brought up was that whatever process we follow, it should not, in theory, change the order of what we would do normally. And if we do it that way, it may fall within social acceptability, so to speak, because it's not perceived as changing what we would do for the patient themselves. But even in DCD currently, having partaken as the physician involved, we say that it's not different than what we would do normally in withdrawal of care, but the act in and of itself changes things. In fact, I am now present rather than just writing an open-ended order for nursing, because we go to the OR, I'm present, and the nurses have made the comment, well, you're using higher doses of sedative medications than we're comfortable with, and I say, but I am comfortable with it, but now that's changed the way in which withdrawal of care would have happened. So I can see a very slippery slope as we get into different versions of withdrawal of care or MAID, because in and of itself, it absolutely will, in some shape or form, change the process. It cannot be exactly the same. And so that perception of, or statement of not changing the process, it's a little difficult for those of us, even in DCD, for example.
Yeah, and the administration of pre-mortem interventions to facilitate DCD is another way in which things are changed by by donation in that context. I think the difference, in this case of MAID followed by donation is going to be that you have a competent, conscious patient who can be told about all these facts and the ways in which both the MAID and the organ donation will influence each other. So there's a possibility of informed consent in this context, which wouldn't be present with a brain-injured patient that you're trying to decide whether it's okay to administer all kinds of heparin or something like that, which is not strictly in there for their benefit. So I think there might be a partial difference there, but I do think also there's the public relations and the public trust context, and we are bringing together here, especially MAID is highly controversial, organ donation less so, but it still remains sensitive for some. So caution, I think, is advisable, and doing very radical kinds of things, even if someone wants them, one would have to be rather careful.
Jennifer, thanks very much for an enlightening talk, and we realize there's no clear answers at this stage, but it's important to work through the issues, and as people work through them, there's lots of discomfort, right? Physician-assisted dying is a monumental shift in the culture and practice of healthcare. Organ donation confounds that monumental shift in culture and practice. If the government comes to you today, I'm going to put you on the spot, and says, Jennifer, what's your opinion? Should we just first proceed with physician-assisted dying and then wait a little bit, take a prudent approach, and wait before we open it up for organ donation? Or should we do them both at the same time? Meaning, should we stagger practice? Let's do physician-assisted dying in this country, in this province, for a number of years. Let's work out some of the problems that will inevitably arise before we go into this. Or should we, in fact, say no, because patients might ask, we got to be prepared to respond appropriately and have guidelines in place and recommendations. Does that make sense?
That's a good question. Well, if I compare it to what happened in the Netherlands, that was a country that had had some time to get comfortable already with MAID. They had it as part of the culture. And then when the case arose, I want to do organ donation, there was a big backlash, a fuss. So one could just follow that route and wait for that case and then try to respond. But I don't know, someone's going to have to tell their patient, no, you can't have this, even though it would
advise us.
Advise you?
Tell us what you think that
I think that the colleges should be thinking about this and think about what to put in their policies that will make it clear when this comes up so that there's not a mad scramble to figure out what's permissible and what's not. I think perhaps it's not wise to sort of have some great big it shouldn't be necessarily in the legislation. I think we need to figure out the practice first, but I think it should be thought about now, and perhaps in the guideline formation stage.
Yeah, that was a very clear summary of the issues. Really appreciate it. But I was listening to you and going through thinking of the logic of it. It's a classic dilemma. So you have two competing rights or issues. So one, you've emphasized a lot, the patient may come up and say, I want to do this. Law suggesting that you have to protect these rights through the Constitution. But on the other side, we also have this duty to, for the greater good, make sure people aren't exploited and taken advantage of. And so we have these two competing issues which both have values. Thinking them through, and we often deal with this on a regular basis clinically, the principle I would like to see used is the one that I would look for the most is the safety side. Yes, the patient may feel better and feel like they've gone through all that, but that public safety issue and the issue of being exploited and taken advantage of is such a concern to me that when I'm faced with these two equally valid arguments, the only way I break the dilemma is put on the side of safety. And even though it's an arbitrary decision and people may be upset, it's like tough. It's just safer for everybody in general to go that way.
Yeah, and of course you're right. And this is the reason why in 1993, when there was the first case around MAID, it was turned down because people were worried about the slippery slope, about the exploitation of the vulnerable, and shuffling people off into MAID by virtue of lack of access to adequate palliative care, and people trying to get access to inheritances and free themselves of the burden of a disabled relative. So those were all present in 1993 and were considered again by the Supreme Court in 2015, looking at the evidence of how MAID has unfolded. And there's disagreement on the evidence about whether there has been a slippery slope and whether there has sort of started to shift into categories of people that it ought not to. But in a way, the Supreme Court has sort of made that decision for us, I think, in terms of how serious the risk is versus the need of dying patients that are want-made. I think for the individual physician, it's been pretty clear along the lines that, and the Supreme Court was clear, that nothing in their decision would force any dissenting physician who thinks they don't want to do it, they're not required to do it. And so now we're having to sort out sort of what conscientious objection would look like, and in the Quebec context where an institution has to provide it, how to work within that as well. So Supreme Court has made a social decision about how to balance those two risks.
The organ donation, though, becomes...
Oh, the organ donation part. Yeah.
Another stage up.
Yeah.
Thank you, Jennifer. I'll just ask you one of the slew of questions I jotted down while you were talking. And as a transplanter, I'll think, I'm not involved in the care of the dying, but of the people who are on the list. And so, in the context of a clearly expressed and eligible candidate for MAID being refused, is it theoretically possible that people on the list who might either die waiting for a liver or suffer irreparable harm by staying on dialysis hold the institution responsible for a failure to provide those services, assuming, of course, that they would somehow know that the opportunity was lost?
I think that's an extremely good question and a really complicated one. I think it would be hard for any one individual to establish the chain of causation that a given denial would have produced an organ that would have gone to them, and therefore, so establishing that kind of causal linkage will be very, very difficult. I think that looking at kind of a class action-y kind of model where as a class people have been disadvantaged, I'd have to think more about what that would look like legally, and it would probably differ between Quebec and the common law provinces as well. I think it's unlikely. By the way, I did come across one case in Netherlands. I'm still trying to get access to this decision, but not in the organ donation context, but it's sort of just to have you thinking along the lines of liability in refusing to provide care. There was a case of a woman with lupus, I think, who had, in the Netherlands, Milo de Moor was her name, who got consent for voluntary euthanasia. And then sometime before, the doctor changed their mind and said, actually, no, I'm not going to provide it. She then went and hanged herself. And the family is now suing the doctor for the infliction of emotional suffering brought for them, actually, in dealing with the violent death of their daughter. So it's an interesting case because we often think about liability for wrongly providing MAID to the wrong people. And here was a liability claim essentially not about refusing to provide it, but botching, essentially, reneging on a promise to provide it. So it's interesting. I'd love to get my hands on that case, actually.
We'll do one more question, most appropriately. G.
Thanks. Jennifer, I wonder if you could clarify for us also, in general, in terms of organ donation, but especially now with everything you presented with us with, there's, in Bill 2, one has a sense that the spirit of law is to really strongly promote the notion of patients having control of their own lives, and so the advance directive part was another part of the bill, right? Once I write this in my advance directive, unless you can prove I wasn't informed, I didn't know, I was incompetent, you have to, we're going to have a registry, we're going to follow that. With respect to organ donation, and this practical experience seems to be, no matter how informed an advance directive you would make with regards to this, the sense has always been, and the advice we often seem to get from legal is, nevertheless, once you're dead, all bets are off, and you're not there anymore. You're not a legal entity, so there's no obligation to actually fulfill an advance directive for something like this. And if the body, which is not a person, belongs to anybody to have a decision, belongs to family, and then they can come in and say, I don't care about what he or she said ahead of time with respect to any of this, we're saying no. That's some of the paradox we've been struggling with. Do you have any sense of how that might play out here?
I guess it would be a little bit different because you'd have a living person contemplating PAD who would be complaining about a refusal. I guess, so you don't get the awkward position of not a living rights holder to actually complain about the fact that you didn't follow through, which would be a different case. So that's the only distinction I would make, if I've understood the question correctly. Yeah.
So thank Jean, and thank Jennifer Chandler, and thank everyone, and Stephen for having organized this, and we'll probably do it again.
Canadian Bar Association is going to be evaluating this?
No, I'm not. Yeah.